start. Okay, so that one's done. So as I say, oh, Pauline, would you like to pop your camera off?
Right, that's it.
Super, that's it, thanks. And then it just makes it easier for the editing later. Brilliant. So we've got Laura Goodwin from Lancaster University and Phil Parks, who works for an organisation called Expert Citizens. Yes, I always want to say Expert Voice, and that was me just trying to remember that. I'm babbling now in the recording, which is brilliant. Laura won funding to run a workshop last year. In fact, I think you did 2 workshops.
You did 2, yeah.
And so she's going to tell us about those workshops and what they did. And I'm going to let you explain, because I'm sure you're going to say all of this. But we're really pleased to have you here. And we're looking forward to hearing your presentation. So I'll let you take it away.
Great, thank you. So I'll try and just share the slides now so that is sorted. That okay? Can you just see the slides and not the note pages?
Yes.
Yeah.
Great.
Thanks, Laura. I'll pop my camera off as well.
Okay, so we're going to just start by both Phil and I introducing ourselves. So I'm Laura Goodwin. I'm a senior lecturer in mental health at Lancaster University. So a lot of my research, my previous research really has taken a kind of epidemiological approach to understanding how commonly mental health and alcohol use disorders co-occur, and also understanding which groups these problems are most likely to co-occur in. But I've been doing more work over the past couple of years or so, looking at how we can improve care for this population, because we know that often people with co-occurring problems aren't getting access to the treatment that they need. So that's what we're going to be talking to you about today. I've been working with Phil for about 2 years now on different projects. We started out, we were in touch around some research looking at the longer term physical health outcomes for those with physical health outcomes, and then Phil's been more involved in different research projects, and he's been a co-I on a project on an 18-month project that we've just got funded by the NIHR. So Phil, do you want to introduce yourself?
Yeah, thank you, Laura. Good afternoon, everyone. My name's Phil Parks. As said before, I work for Expert Citizens, which is a lived experience organisation in Stoke-on-Trent. By that I mean that we've all got a lived experience of one form or another, and we also work with people with lived experience because we believe that they should be involved in the decision-making processes. I've been working with Laura for a few years now. We started on a multiple morbidity programme, which I was part of the workshops, and then obviously I've been part of the workshops for this, and then I'm co-I for a forthcoming paper project.
Great, thanks, Phil. So we're going to share the presentation between us, and also just to acknowledge the other people who've been involved in this work, you can see listed on this slide, who are from Lancaster University, Newcastle University and Manchester University. So we had funding from the 3 Mental Health Schools programme, and we were aiming to do 2 things really through these workshops. One, we were looking at the different treatment pathways experienced by people with co-occurring problems, and what the kind of positives and negatives are of these different pathways. And then we also wanted to conduct a priority setting activity, and we'll talk to you a bit more later about how we actually managed to do this over 2 workshops, which is quite an abridged sort of process compared to other priority setting processes. So in the presentation, I'll just start by giving a quick overview of what we already know about the links between mental health and alcohol use. I'll give you an overview of the current guidance for treatment, and also the different treatment pathways that people are likely to experience. We'll talk to you about what we did in the public workshops, and then Phil's going to talk through the findings of the workshops, so both what the most common treatment pathways were and the positives and negatives, and then he'll also talk you through the outcomes of the priority setting activity, and then we'll finish with us both talking through the clinical implications of this work and also the next steps. Not changing. Okay, so I'm just going to show you a couple of graphs really, which are around the level of association between mental health problems and alcohol use disorders. And we'd term an alcohol use disorder as someone who's drinking at a harmful or dependent level. So you can see from this graph that people with a range of different common mental health problems like depression and anxiety, they were slightly more likely to drink at hazardous level compared to those without the mental health problem. But actually for harmful and dependent drinking, there was much higher odds of people drinking at harmful levels, so around a 4-fold increase in odds. So in real terms, that was we had around 3% of people in the general population drink at harmful and dependent levels, whereas for people with these different common mental health conditions, we've got around 10% of people drinking at harmful and dependent levels. If we move on to look at more severe mental health problems like bipolar, psychosis, and antisocial and borderline personality disorder, the ratio of this graph is actually different. So the odds of harmful and dependent drinking are even higher. So whereas they're around a 4-fold increase in odds for people with a common mental health condition, we've now got for bipolar and for antisocial and borderline personality disorder, we've got around sort of 7 to 9-fold increases in odds. So for some of these conditions, we've got up to like 20% of people with the severe mental health problem drinking at harmful or dependent level. And as I said, that compares to around 3% in the general population. It's a slightly different picture for probable psychotic disorder, and that's because a large number of people with psychosis actually don't drink at all. But for most mental health conditions, there is a much greater odds. But given all that, we would think that there would be very sort of clear pathways in place for people with co-occurring problems to make sure they can kind of easily navigate healthcare systems, because they require treatment for more than one condition. Actually, I don't think that's often the case for people. There's a lot of discussion around what's the direction of the association between mental health and alcohol use, which comes first. And there's kind of 3 theories around this. So one is that drinking heavily can result in people's mental health worsening, and this could be both through the biological effects of drinking heavily, but also through some of the negative social effects of having an alcohol use disorder. For example, someone may become more socially isolated. We also know that as someone's mental health declines, they may be more likely to increase their alcohol use in response to this and to use alcohol to cope. So that's the other direction from mental health to alcohol use. And then the third theory is actually there may also be common risk factors for both problems, such as exposure to trauma or experiencing adverse childhood events. There's some research that's tried to establish kind of which direction there's more evidence for, and actually this has shown that whilst both relationships are definitely plausible, there's more evidence for the association from declining mental health to an increase in someone's alcohol use. So we know that these problems are common, they commonly co-occur, but what we also know is this population are more likely to experience barriers to getting the care that they need. So people may use alcohol to cope with mental health symptoms, and they may be doing this trying to deal with a problem by themselves. So they may actually delay trying to seek mental health support. Alcohol use can also provide a barrier to someone getting mental health support once they decide that they want to try and get that support. So someone might make the decision that they now, they feel that they want to get some support for their mental health, but actually they're then told by services that they can't be seen until they reduce their drinking or stop drinking. And obviously this can be quite a major barrier, particularly if someone's using alcohol to cope with their mental health. There's evidence looking at IAPT services that if someone's drinking at hazardous or harmful level, they're more likely to drop out of the treatment, but if they do stick with the treatment, they have equally good treatment and clinical outcomes. So that means we need to be doing more to try and help people to adhere to their treatment sort of program, because the outcomes can be just as good. And we also know that in terms of drug and alcohol services, that sometimes people with more serious mental health problems are told that their needs may be too complex to be seen by that services. So there's a range of reasons why people may not always get the support that they need. We're going to talk in the results about the different treatment models or treatment pathways that people can experience, and I'll just talk you through the 4 different treatment pathways. So you can see 3 on your screen. The first is serial, and for serial, this is basically 2 different types of treatment pathways. So this is when someone sees one service first and then they see another service second. And so the ordering of this can be someone sees the drug and alcohol service or the addiction service first, and then they see the mental health service. Or the reverse could be, and the second option is someone sees the mental health service first, and then they see the drug and alcohol service second. The third treatment pathway we've got is that people actually receive treatment for both their mental health and alcohol use disorder at the same time. So this is parallel, but it's provided by 2 different services. And then we have integrated care, and that's where both mental health and alcohol needs are addressed at the same time as part of an integrated package. And that should involve more sort of communication across the different areas of care. It doesn't have to be delivered in the same location by the same person, but sometimes it is provided in the same location by the same service. So that's a more integrated programme. So there's 4 different types of treatment models that we were interested in this work. I mentioned that we'd talk to you about the guidance as to what should be happening. The most recent guidance from what was Public Health England was in 2017, and that was the document, and I think some of these links are going to be available through the chat maybe. This was around better care for people with co-occurring mental health and alcohol or drug use conditions. And there was some more specific criteria around kind of collaborative working approaches, but the 2 key aspects of this guidance was around that the care should be everyone's job. So someone having co-occurring problems should be seen more as the norm rather than the exception. And there's a requirement that the mental health and the alcohol and drug services work collaboratively. So it's about that collaborative care, which what we found it isn't actually always the case in reality as to what's happening. And there's also this guidance suggested that there should be a no wrong door approach. So that basically means that someone shouldn't be turned away from services because of the fact that they've got co-occurring problems. But actually, we know that sometimes this is still happening. For example, someone being told they can't access their mental health treatment because of their alcohol or drug use. So in terms of what we wanted to do for the workshops, we wanted to first look at, out of those 4 different pathways, what were the most common treatment pathways? and whether the treatment model was serial, parallel or integrated. And then once we'd found that out, we wanted to look at the positives and negatives of each of these different treatment pathways. And then the second element of the work, as I said, was to develop a list of priority areas for research. And that would be research to improve the care of people with co-occurring mental health problems and alcohol use disorders. In terms of what we did, so we had 2 workshops. They were both online. We decided to run them online because we wanted to make them more accessible for people. And in previous work, people have told us it's easier for them to join a kind of online event. And also we wanted both people with lived experience and also the professionals who work with them to attend. And it might be easier for someone to come along to an online meeting rather than have to travel somewhere. And we had people from across the Northwest attending, so it would have been quite far for some people to travel, say if we'd held it at Lancaster University. So we had 7 people at the first workshop, so slightly lower numbers, but then we had 18 people at the second workshop, so that was much better attended, and everyone was reimbursed for their time, and so thank you for taking part, because it was quite a time commitment. In terms of what we did in the workshops, then both workshops, the first half was spent talking about the different treatment pathways and going through what the positives and negatives were of each of these treatment models, and that was undertaken in smaller groups. And then in the second half of workshop 1, people were asked to propose research questions which they think would be important to address to then improve the care of people with co-occurring problems. And then between workshops 1 and 2, we had quite a range of questions, and we tried to refine these as a research team to get them down to 20 questions. But actually that wasn't as difficult as you might think, because there was a lot of overlap between the different questions that have been proposed, so quite a lot could be combined. And then in the second half of workshop 2, we then ranked these 20 questions using a process based on the James-Lint Alliance. So we were able, by the end of workshop 2, to have a sort of top 10 list of research priority areas or questions. You may be thinking, how did we do that? If you're familiar with the James-Lint Alliance guidance, that is a process that can take 12 to 18 months with quite a large research team. So we only had the 2.5-hour workshops. So we just tried to do what we could to kind of use the guidance as a template for us, and to try and ensure that the processes we were using kind of would reflect everyone's views, but we obviously had to do this as an abridged process. So in the first workshop, in terms of the priority setting, we used online Padlets that both the facilitators could write into, but also people from the small groups could write into them. And we tried to group these the research ideas that were put forwards in these discussions into a number of areas, and that helped us then when we were synthesizing these questions and trying to get 20 questions together. The reason why we had wanted to get it down to 20 questions to start workshop 2 was because we only had a limited amount of time, and we thought any more than 20 it would be a really hard task to ask people to then rank those, whereas 20 seemed like a kind of reasonable number, and it was feasible for all of the groups to do that. And then in workshop 2, so we started with the 20 questions. People were in small groups, and they had lots of discussions around how they would want to rank the questions. And I think in most of the groups there was quite strong agreement. So then we had 3 lists of ranking, and we were able to combine those to get our kind of final ranking. And then at the end of workshop 2, we had some final discussions going through this, getting people's feedback around any questions that they thought should be kind of combined, or They were asking similar things, and there were some examples that people did propose that we were able to apply. And then final feedback, that all the results were circulated to everyone and people could provide final feedback by email. Okay, so I'm going to pass over to Phil now to talk through what we found in the workshops.
Thank you, Laura. As I said before, me and along with a couple of my colleagues were in attendance to these workshops. What we did find is the majority of people, like over 75%, found the serial treatment pathway, that was alcohol and then mental health, was the one that they had experienced. During the discussions, we found the positives to this way of working was it was easy to engage with mental health treatments after you reduce your alcohol intake. That therapists and alcohol services can give you tips on how to cope with your emotions. People's mental health can improve after treating the alcohol problem, though it depends on the complexity of the problem. Some of the negatives that came through this were the wait times for the different treatments. It could be quite great, like after you'd experienced a residential alcohol treatment, then going into a mental health problem treatment place. People become acutely unwell quickly, and alcohol services cannot offer specific mental health support if needed. And it's the lack of appropriate coping skills to cope with mental health issues if the people returning to the same circumstances that they were when they were actually using the alcohol. So it was an issue. I actually went through this sort of treatment plan myself, and all the things that came up in the study actually resonated with me. That there's a lot of thought process that you should have to be able to cut down on your drinking, which I do agree with in principle, that you can't have certain treatments like CBT whilst you're intoxicated, but some of the other therapies may be beneficial to be had whilst you're still trying to withdraw from drinking, but we'll come on to that part later. The second treatment pathway was a serial mental health, then alcohol treatment. People found this was helpful if the individual was able to control the drinking. It was easy to address their alcohol issues if their mental health is stable. And they can tackle the underlying causes of the alcohol or substance misuse. If the alcohol is being used to cope with the mental health problems with people self-medicating, then they found it easier. So the negatives to this course of action was the eligibility for mental health services can be affected if you're using alcohol to self-medicate, which is something that, again, I found where I was told that I couldn't engage in treatment whilst I was still drinking. You have to be seen in crisis for your mental health to be seen, that sometimes they will pass it off as it's just an alcohol problem, it's not a mental health problem. You have to be really bad with your mental health before they even class it as a mental health problem if you're in addiction. And if someone is still self-medicating, this can prevent mental health treatment from being effective, as I discussed before, with CBT and things like that. If you're still self-medicating, if you're still in addiction, then it doesn't work. Again, I've gone through, I think, all 4 treatment pathways, and the positives and negatives to this one kind of really ring true. It's hard to try to get the help you need if they're not trying to treat both at the same time, in my personal opinion. Then we have the parallel services, which is when they're both treated at the same time but by different services. Some of the positives from this was that you're not reliant on one service having all the answers, that there's more eyes looking in on the problem, if you want. There's you can benefit from them people being specialists in their given area. Having separate appointments for each problem can remove the stress of having to address everything at the same time, and it kind of can provide a more holistic approach. So each service might look at things on a different level and can give you different points of view and how to try to make yourself better. But some of the negatives are the lack of communication between services, and there's a GDPR regulations where it means that some of them will not be able to share certain information, which there should really be an umbrella sort of data sharing process there, but unfortunately there isn't. There's separate services may miss the interconnectedness of the problems, so they might only focus on their specific, like alcohol or drug and or mental health, and not try to treat them as both and one and the same sometimes, which they can be anyway. And there's not enough mental health knowledge in alcohol services, which yes, and it does not take a trauma-informed approach, so they kind of keep asking you to repeat the story, even though it could be a traumatic experience, to keep on relaying the same information back over and over again. And as I said, in my experience, the biggest worry was the lack of communication. It was the poor data sharing. So you could be getting somewhere with one service and the other service that doesn't know, and it can cause quite a bit of an issue. But if you are getting really good service from both areas and you're getting specialists in both places, then it can be a benefit. It's trying to find that lovely little happy middle ground where they're actually talking to each other, which is few and far between, to be honest. And then there's the integrated, which there's, I think in Stoke-on-Trent, we have one dual diagnosis worker. I don't know what it's like in other areas. So this is where the services are treated at the same time by the same service at the same time. Which, as I said, there's not many dual diagnosis workers in Stoke-on-Trent. I don't know elsewhere, but this means that this service is not everywhere. It's not as forthcoming. The positives that it helps to deal with everything at the same time in one place. There's less communication issues, and it can lead to better outcomes for the users. The therapists know all about your mental health and your addiction services, so you don't have to keep relaying your own story, which again, like I say, can bring up past traumas. And the better integration of other organisations, so they all both know which recovery service is best for you to go into once you're through your treatment plan. Some of the negatives from this is that to be effective, you need to know there's a good aftercare plan in place just to put you through the service and the treatment, and then leave you to go about your business doesn't work. Concerns about information sharing that this is provided by your GP or NHS. Some people don't want to know that everybody's got all their information, and somebody doesn't want to disclose their information if it could be easily accessible by somebody who, like your boss or social services, who could then, well, who they would think that it could be used against them, but obviously this should not be the case. And it may require service providers to have expertise and specialist skills to support both areas. Yeah, as I've said before, there's very few dual diagnosis workers, to my knowledge, who have actually got specialisations in both areas. So that can be an issue, and it's too overwhelming to deal with both problems at once. Well, it can be too overwhelming to deal with both problems at once. In my personal opinion, through going through all the different treatment pathways, I found this one to be the most effective, merely because I'm in the school of thinking that both addiction and mental health are both trauma responses. So to be able to have them both dealt with at the same time, maybe in different ways, can help you to overcome said trauma, and then hopefully help you to engage in recovery better. And as Laura said, we at the end of the first workshop, we developed a list of 20, and then throughout the process of emails and then into the second workshop, we narrowed this down to 10 questions. Some of these ended up being groups of questions which were merged into one question because there was a lot that we wanted to be answered. But the top question that we came out with was, where are people with co-occurring problems most likely to present, and does it depend on which condition is developed first? As I've said previously, that I believe that they're both reactions to trauma, so I don't know which. I'm not sure on which comes first, but we thought that in the case that one does develop first, it'd be very beneficial to know what the most likely one was to develop first. We've got what are the needs of the carers and family members of people with co-occurring problems, and how can they be better supported. This again is something that I found when I was doing my treatment, that nobody asked about anybody who I was living with, working with, my family members. They kind of be left by the wayside, and based on my knowledge and experiences, that they can be really badly affected by somebody who's in active addiction and with poor mental health, because I put my family through the ringer a few times probably. And then, what does an integrated care system look like? What does people with people co-occurring problems? Is it people who are a specialist who has both specialisations, or is it a service that has very good communication and separate workers with specialisations in addiction and mental health? We had a bit of a long-winded conversation to decide which would be best, and I don't think we came to a solution to that conversation. So I think to look into this more deeply will hopefully give us an answer of what may be the best solution to work for most people. And then we looked at why peer support and guidance from people with lived experience can be helpful to people with co-occurring problems. Looked at what the barriers to services are. They're both mental health and alcohol services being integrated or working more closely to support people with co-occurring problems. Looked at what are the service user experiences of different treatment pathways, because as I said, if they're like me, they've probably experienced a couple of the treatment pathways before they found one that worked for them. How can we involve people with co-occurring problems who aren't accessing services and research? Me and Laura had quite a few conversations regarding this, because not everybody who has got comorbidity, multiple morbidity, is actually seeking help for it because they feel like they're self-medicating, they're dealing with it. So it's going into some of the support services where these people would present. It's social prescribing. That's identifying where to put people into these support groups or community groups so they can help themselves. Is that helpful to people with co-occurring mental health and alcohol problems? We've got what are the skills and training needs people are working in mental health services to support people with co-occurring problems. Again, this is where being trauma informed may rise its head in the research, but we've not got there yet. And then how can we involve groups who may be less likely to access treatment and research, and that there'd be people from like ethnic minority groups, LGBT groups and things like that. But these are the 10 questions that came up, and as I said, there was quite a few of these were grouped questions where we came up with a few different ones where we've merged them together.
Great, thanks, Phil. Sorry, did someone say something then? No? Be hearing things. So in conclusion of what we found from these workshops, then we did find that having these public workshops really provided valuable insight into the different treatment pathways. We found that serial treatment, so having alcohol followed by mental health treatment, was most common, but also feedback that this may not always be the most appropriate, and actually it may depend on the individual's needs, and so that should really be taken into account when the decision as to what treatment pathway someone's getting is made. We were really pleased with the outcomes of the research priority setting, and it's highlighted lots of important questions to answer going forward. Some of those we're going to try and answer through our research, but we are going to be publishing this work, so we hope that also other questions will be able to be answered by other people as well. And whilst I wouldn't say we did the perfect process in terms of the priority setting, it did feel like a valuable process, and it showed that you can do this in a shorter time frame if you need to. In terms of the next steps and the implications, so Phil showed you some of the images. We kind of had a summary image for each of the 4 treatment pathways to give an overview of how people may find and experience those different pathways. So we're now going to be working with different organisations and with Phil to think about how we can best disseminate those, and we want to make them like freely available for organisations to use. Phil, did you want to say something else on that?
We found the images, I showed them to some of my colleagues at work, and we found them to actually, they did what they needed to do, but they were simple enough to take in, so it would be beneficial for actually the academic side and the third sector side. So they actually do what they need to do, and they're simple enough to take in.
Yeah, thank you. And so Phil and I have submitted a joint presentation for the UK Society for Behavioural Medicine, so we're just waiting to hear whether that's been accepted. We've been funded by the NIHR for a programme development grant on improving treatment pathways for people with co-occurring mental health and alcohol use disorders, so we're starting that very soon. Phil's the PPI lead on this project, and having these workshops will really strongly influence this work, and it's been really helpful to inform that. Phil, do you want to say anything about the sort of PPI work in the grants?
As part of my role as PPI lead, we will be communicating with, I think there's a couple of groups in Lancashire we've already started to touch base with, to actually have a lived experience eye on all the findings. So there's going to be a lived experience section and all the research, which I think is very beneficial, because as I previously said, my organisation where I work with fully believes in having lived experience as part of the decision-making process. I think that working with lived experience and learned experience in this way is going to yield the best results.
Great, thanks. Yeah, part of this project is going to be to try and develop, well, not just as part of the programme development grant, but if we then go on to do programme grant, the plans would be to develop updated public health and clinical recommendations and guidance, but also in parallel to this to develop specific guidance for service users and their families, because that was something highlighted within the priority setting activities, but we also know that often it is like a family member who might be sort of advocating for someone's treatment and trying to get them the help that they need. But if they don't, things are so, as you will have seen from, you know, the presentation today, things are very complicated in terms of the order and what someone can access. So that could be quite tricky for a family member to understand and know what eligibility criteria might be. So that's something that we want to develop separately to the kind of clinical guidance. And any new recommendations should strongly take into account the different treatment pathways and how sort of tailored for an individual they should be. Okay, so I think we're getting it's towards the end. So just to say thanks to the 3 schools programme for funding these work, and also to thank the organisations that supported developing the workshops and helped us recruit people to attend the workshops. Yeah, and to thank Phil for all his contributions and for presenting today. And you can contact either of us, here are our details. So yeah, thanks for listening, everyone.